Welcome to this webinar presented to you by PALPRAC in collaboration with SunPal Echo and the Western Cape Department of Health on the recently published clinical guideline on providing palliative care in South Africa during the COVID-19 pandemic. This presentation will mainly be on the first part of the guideline, dealing with the care of COVID-19 positive patients. It is hosted by myself, Dr. Renee Krause, and Dr. Katja Evans. We would like to thank you for taking this time to join us. These are complex times that affect all of us in different ways. We also want to draw your attention that the Department of Health is committed to compassionate, dignified care from the beginning until the end. PALPRAC is the Association of Palliative Care Practitioners of South Africa. We are a non-profit organization that was formed in May 2018 by a group of South African doctors from various fields of medicine who have advanced training in palliative medicine. Our mission is to enable the provision of palliative care, which is care that improves the quality of life of people with serious illness in both the public and the private health sector of South Africa. Never has it been more important than now in the face of COVID-19. We hope that by offering this training in palliative care, all healthcare workers will begin to understand that there's always something we can do for patients and families with advanced illness, and that nobody needs to suffer unnecessarily. SunPal Echo is a collaborative project between Stellenbosch University and the Project Echo at the University of New Mexico. Project Echo was established as a telementoring network aiming to close the distance between academic medicine and the front line through virtual clinics. SunPal is Stellenbosch University's palliative care echo clinic that offers telementoring to healthcare workers in the Western Cape through regular virtual case discussions and didactic teaching sessions. The PALPRAC guideline was created in response to the COVID-19 crisis through a collaborative approach of its members across South Africa. This guideline is an evolving document, and through these webinars, we hope to engage doctors from all sectors of the healthcare system to critically consider how palliative care can be integrated into the patient care and to give us feedback on possible gaps in the guideline or areas that also need to be clarified. We therefore encourage you to post questions in the chat bar during the presentation or to send us an email at info@palprac.org or to visit our website. Introduction: the principles of palliative care and how palliative care is aligned with the COVID-19 care patients receive. Palliative care aims to ensure that patients and family receive dignified, compassionate care during this pandemic. Palliative care does not only describe end-of-life care, but the relief of symptoms and suffering for all, whatever their COVID status or final outcome may be. Palliative care intends not to hasten death or prolong dying, and must be provided alongside standard care. Palliative care can be provided anywhere, in the ICU, general ward, intermediate care facility, or in the home. It is best provided by interdisciplinary teams consisting of clinicians, nurses, social workers, and spiritual carers. Teamwork ensures high-quality palliative care and reduces the burden on healthcare workers. We would like to encourage you to seek out the members of your healthcare team now that contribute to the unique skills to provide palliative care for patients in your setting. PALPRAC is also offering mentorship from experienced palliative care doctors during this time. Again, I want to draw your attention to the website.
In mild, moderate, and severe COVID-19 cases, patients require symptom control and psychosocial support, with their needs heightened in particular in patients with pre-existing palliative care diagnoses. Critical COVID-19 patients probably need mechanical ventilation. Mortality rates in this group are incredibly high, and therefore a palliative care approach should be integrated alongside life-sustaining treatment. Psychosocial support of both patient and family are high priority. The last category of patients are patients that are not expected to survive with the current care available. These patients require urgent palliative care interventions. In the webinar moving forward, we are going to look at hospital-based palliative care for 3 groups of patients. The first being those that are failing ventilatory support. The second, those with severe symptoms that are not candidates for ICU and ventilation should they deteriorate. And the third being end-of-life care for those who are not expected to survive the COVID-19 disease. Many of us work in a resource-constrained environment already prior to the COVID-19 outbreak. And we understand that there are difficult decisions to be made. Resources have to be allocated effectively and fairly, even more so in a pandemic. We have to consider distributive justice. Resources include not only gloves, masks, PPE, but also hospital beds, nursing staff, critical care spaces, and medical equipment. We have to give the right care for the right patient at the right time. Where possible, decisions should be guided by a patient's wishes or advance directive. We know that there is a worldwide shortage of critical care beds during this pandemic, and in particular, we know that patients have a long length of stay in the critical care bed when admitted. Ideally, critical care bed allocation should be done by a team and follow established triage guidelines, and also be a separate group from clinical staff delivering care to patients. Patients with hypoxemic respiratory failure and ARDS who were initiated on ventilatory support but who fail to respond to intensive therapy may need to be considered for withdrawal of ventilatory support. Withdrawal of ventilatory support in COVID-19 positive patients require a different approach to traditional extubation due to the unique challenges involved. Firstly, one has to consider staff safety. Extubation is a high aerosolization risk procedure for healthcare workers. Secondly, different to our normal practice, there is no family at the bedside. And lastly, there is a constant time pressure because the ventilator is potentially needed right now for the next patient. We recommend a stepwise approach. Step 1. Decision has been made to withdraw ventilatory or inotropic support by the emergency medicine or critical care team. Document that decision in the patient's clinical notes. Step 2. Family communication. Use the communication guideline to assist you with having these difficult conversations and document those conversations in your clinical notes. Step 3. Assess the projected timeline of death after cessation. This can either be rapid or delayed. Some predictors of rapid decline include a high PEEP, high FiO2, inotropic requirements, severe acidosis, or an obtunded patient. There are many other factors that may come into your assessment or decision making. We anticipate that most patients with COVID-19 where withdrawal of ventilatory support is being considered would fall into the rapid timeline prediction. Our approaches differ slightly in these 2 groups. With the rapid death anticipated group, the risk of extubation outweighs the benefit due to staff safety concerns. If this is anticipated to be a delayed dying process, extubation is required as immediate death is not anticipated. This requires a clear protocol to avoid putting staff in danger. Whilst specific details may vary according to facility and individual guidelines, a recommendation for a projected timeline of rapid death includes a basic stepwise process of initially ensuring that your neurovascular blockade agents have worn off. Turn off the bedside monitors and use a complete symptom-based monitoring approach, assessing pain, anxiety, and restlessness. Stop inotropic infusions and gradually scale down ventilatory support whilst titrating medications to control dyspnea and anxiety up, ensuring the patient is comfortable. Decrease your ventilator settings, reassess every 5 minutes and give additional boluses of IV morphine if needed for breathlessness or pain. If on an ongoing infusion, titrate accordingly to symptom response. If the patient becomes restless or anxious, give small boluses of benzodiazepines to ensure patient comfort. Do not extubate the patient until either after death in the hospital or in the mortuary as per local policies stipulate. If a delayed death is anticipated, use a similar approach as for rapid, however, the following adjustments should be made. Add intravenous buscopan for secretions. Minimize the number of people in the room during the extubation procedure. Ensure patient is appropriately medicated to avoid coughing. Once the patient is comfortable, suction the airway and perform palliative extubation using appropriate technique and full PPE as per intubation. Immediately after extubation, ensure face is covered with a surgical mask and consider nasal cannula as required. Continue detailed care as per the end-of-life guideline, which will be discussed later on. We know that a large proportion of patients with COVID-19 never need ventilation or critical care and respond to supportive treatment and recover. It is, however, becoming very clear that patients with chronic comorbidities are more likely to have severe COVID-19 disease, but are also less likely to be allocated critical care beds and ventilation in facilities where these resources are limited. It is therefore critical that all patients with severe COVID-19 symptoms who would not be ICU candidates if their symptoms worsen should be considered for early supportive therapy, including supplemental oxygen with or without empiric antimicrobials as per the standard treatment guidelines. Unless resources do not allow for this, or if the patient or their medical decision maker clearly states that they decline such therapy. These patients and their families are particularly vulnerable on a psychological and emotional level as they realize that critical care and ventilation are not available to them. It is therefore crucial to address their fears and anxieties while relieving their dyspnea and anxiety with impeccable medical care. Also consider that on a physiological level, dyspnea and anxiety are closely linked and they can escalate each other if symptoms are not managed. Administer oxygen if patients are hypoxemic via either nasal cannula, simple face mask, or non-rebreather face mask as per the standard treatment guidelines, aiming for a saturation of more than 90 in a general patient and 92 in a pregnant patient. In the palliative care guideline set developed, we have acknowledged that different centres have access to different resources and have therefore stratified symptom control management plans according to resources. You will find in the guidelines that there is an option for oral medication administration. There is an option for syringe pump for continuous subcutaneous infusions. There is an option for bolus dosing of subcutaneous drugs, as well as an option for continuous IV infusion via infusion pump. We have stratified this in these different options to allow facilities to select what is most appropriate or available for them. Two main symptoms approached in the guideline are anxiety and dyspnea. We have also included options available for high resource settings such as fentanyl patches and more expensive interventions. Please read the guidelines for more detail on drug dosing and options for dyspnea and anxiety. We have also included some non-pharmacological options.
End-of-life care in the hospital setting. A COVID-19 patient may reach this stage either because they could not be initiated on ventilation or critical care, or after being withdrawn from ventilation. Advanced care planning may or may not have been possible. However, we urge the implementation and discussion of this practice. It is important the attending team be prepared to manage their patient and his or her family in a dignified and ethical manner, minimizing distress and suffering to the end. A bio-psychosocial and spiritual approach to overall care is best. Distressing symptoms are common in the end-of-life phase and must be anticipated and promptly managed. At all times, PPE must be worn and strict infection control precautions adhered to by both the staff and family. Unfortunately, in many situations, the family may not be present, and we will discuss these practices later in this PowerPoint. End-of-life care requires holistic care to enable the patient to have a dignified death and to enable the family to have closure. 5 important areas need to be considered. Medication, the route, how to rationalize medication, and how to prescribe drugs for anticipated symptoms. Review the place of death. In a hospital, hopefully we can provide a separate area for a patient to have a dignified death. Review investigations and nursing procedures. Offer spiritual care, even if it is online. And very important, we need to counsel, educate, and support the relatives, especially during this complex time where they are unable to visit. When a patient is moving towards the end of life, communication is core to the care. Communicate clearly and frequently to the whole team. Make sure decisions have been communicated to the family and all discussions and decisions have been documented in the folder. Evidence supports that opioid dosage do not hasten death in malignant and non-malignant conditions and are safe to prescribe at the end of life to care for patients who are restless or have pain or have severe dyspnea. Symptoms we might expect at the end of life are pain, dyspnea, nausea and vomiting, excessive secretions, agitation, delirium or restlessness, fever. The hydration status need to be very carefully considered in the COVID-19 patient. We recommend the subcutaneous route, which is an effective route to administer medication. It should not be used if the patient is in shock, but is good to use at end of life for end of life care. The cannula can remain in much longer than an IV cannula and it's less painful to recite. Refer to the full guideline for instructions. We recommend the prescription of a low-dose opioid using the subcutaneous route. If you are converting to a subcutaneous syringe driver in an opioid-naive patient, prescribe morphine sulfate 15 mg over 24 hours as a continuous subcutaneous infusion using a syringe driver. Decrease this dose in the elderly or in patients with renal failure. Always prescribe breakthrough doses. That means doses if the 15 mg is not enough. In between every 1 or 2 hours, a patient may receive 1 to 2 milligrams extra subcutaneously. In a patient who is already on opioids, increase your dose by 25% in 24 hours. Whenever we prescribe morphine, ensure that we prescribe antiemetics. Haloperidol is a good antiemetic, especially when we are managing delirium as well as nausea and vomiting. Hyoscine butyl bromide, or better known as buscopan, can be prescribed to manage excessive secretions at the end of life. If the patient is restless, add midazolam to your subcutaneous infusion. Other symptoms to expect are fever. Give paracetamol 1 gram orally 6 hours, and if the patient cannot swallow, this can be provided intravenously. Non-pharmacological treatment includes cool sponge baths and dresses in light clothing if possible. Because this is end-of-life care and we are looking at a short prognosis, the PALPRAC group has collaboratively developed consensus that PR indomethacin or diclofenac can be used at the end-of-life care for patients with COVID. As stated, haloperidol can also be added to manage delirium. Hydration. During this phase of life, especially in patients with acute respiratory distress syndrome, we want to restrict fluids and to comfort hydration and feeding. If you suspect the patient is fluid overloaded, give furosemide 20 mg. Furosemide, or better known as Lasix, can also be provided subcutaneously. In the palliative care guideline for COVID-19 created by PALPRAC, a flow diagram with all the medication can be accessed. When the end of life phase is recognized, it needs to be communicated clearly, honestly, and compassionate to the patient, the family, and caregivers, cognizant of being culturally sensitive. Reassure them that the patient will receive ongoing support and care, and make sure that the message of non-abandonment is conveyed as well. Management should be patient-centered as far as possible and respectful of his or her wishes. Be sensitive that infection risk might not allow for certain patients' wishes to be fulfilled. Try and make an assessment of the patient and family's resources that are available and their needs, especially spiritually. Ensure adequate psychosocial and spiritual support. We recommend that you link with a social worker and or a spiritual carer in advance to ensure that you have a plan on how you will communicate and support the family, even if it is just telephonically. Discontinue all inappropriate non-beneficial procedures. It may be unnecessary to keep on doing a blood pressure that you are not going to act on, or blood tests that you are not going to act on. However, ensure that the patient is receiving good nursing care, especially mouth care, which can be provided if the healthcare workers are wearing appropriate PPE. Communicate compassionately. In a time of high anxiety, great medical need, and probable rationing of medical intervention, we require skilled and compassionate communication with our patients, their families, and each other. Check understanding of the patient and family of the situation and what they were told before. Give information in small chunks. Avoid medical jargon like ventilator, COVID. Use silence. It allows people to absorb what was said and show emotion. Acknowledge emotion, and the NURSE acronym is a useful tool to use. Name the emotion. You seem worried. Demonstrate understanding. Given what is going on, I can understand you are concerned. Show respect. You have been really patient under difficult circumstances. Demonstrate support. I understand this is very hard. We will be there to help you today. Explore. Tell me more. I would like to understand what you are thinking. Be truthful. Never say there's nothing more that we can do for your mother or for you. Commit to excellent symptom management, compassionate communication, and your presence. Consider linking family telephonically or online to say a final goodbye. Consider arranging a tablet or a phone in a wipeable pouch for the unit for WhatsApp video calls or an equivalent. Nursing care. Create a calm atmosphere. Consider if monitors are really necessary and may cause distress. Focus on mouth care and pressure care. If possible, connect the patient with family and spiritual carers through technology. Talk calmly to patients and reassure them. We would like to advise you to use the Meet My Loved One tool or document, which enables you to deliver more personalized care. This Meet My Loved One document is available on the website. Terminal restlessness is one of the complex symptoms to manage at the end of life. This is irreversible delirium and is common at the end of life. It requires all these 5 aspects to work together to provide excellent care. Excellent symptom control, prevention by detecting it early and managing it. Do not forget to reverse simple, common things like a full bladder. Nurse the patient in a calm and supportive environment, and if possible, use only one carer. Do not do unnecessary procedures and blood tests. You use your communication skills to enable the family in explaining it to the cause and how they should communicate to the patient. Medication is there to be titrated slowly and safely according to the patient's symptoms. Haloperidol and midazolam are the preferred medications to use at the end of life for patients with agitation or terminal delirium. During this difficult time, we must not forget to look after ourselves. We will not be able to offer optimal care to our patients during this healthcare crisis if we do not look after ourselves. We cannot serve from an empty vessel. Under normal circumstances, we as healthcare professionals find that the demands of our work are often exceeding our inherent resources on the physical, the emotional, the psychological, and spiritual level. But caring for patients during a health crisis, especially for those at the end of life, can place immense demands on us. If we do not take responsibility for replenishing our inherent resources on the physical, the emotional, and spiritual level, we will not be able to stay the course during this crisis. And we as healthcare workers are the biggest asset to the system at the moment. We need to recognize this and look after ourselves. Here are some of the specific pressure points to watch out for during this time. Frequently changing directives and circumstances. We as medical professionals function best when there's clear guidelines and structure. In a time of uncertainty, when directives from above have to adapt to changing circumstancing at a dizzying pace, we find that routines and structures that usually keep us going fall away. Compassion fatigue is a mental condition resulting from prolonged exposure to human suffering, particularly in persons working in a people-orientated service like healthcare. It can manifest as exhaustion, irritability, emotional unavailability, and can easily lead to burnout if not managed preemptively. Difficult conversations. Difficult conversations that involve emotions can be extremely draining on healthcare professionals. Lack of teamwork. Unfortunately, very few of us can say that we work in a dedicated team. This may be fine during normal circumstances, but during a healthcare crisis, having a team that you can trust and can rely on can be an immense source of support. Cumulative grief. Not being able to afford the time or the space to express one's own grief at the loss of a patient can lead to a feeling of numbness, dehumanization, and guilt. This type of silent mourning can become a source of chronic stress that leads to burnout and decreased effectiveness. Crossing your personal boundaries. We are all guilty of this, whether it applies to working hours, online access, information overload, or the doctor patient relationship. Only you can define and uphold your boundaries to preserve your physical, emotional, and spiritual strength. A pandemic like this often pushes one to the limits, and we will look within ourselves and search for meaning in all of this. It is very easy to lose sight of what gives you purpose and hope. So, what can we do to build resilience during this time? We need to acknowledge to ourselves that these are extraordinary times in which we need to find our new routines and structure. By teaching ourselves a few communication skills, your interactions with patients and families can become less daunting and more gratifying for all involved. Go and look at the Spikes protocol. Go and look at tools like Vital Talk, which can assist you to improve your communication skills. By understanding clinical empathy through acknowledging and providing a space for the emotions expressed by our patients, we can care for them with compassion, but not suffer with them and burn out. Consider having a grief ritual that allows you to acknowledge your own losses, whether that be the death of a patient or the inability to provide a patient with the care that you would have liked to give. Please take the time to look at this short video on The Pause, a short grief ritual developed by emergency care personnel to use after failed resuscitation. The Pause link is provided on this slide. You need to define your own boundaries, but don't just define them. Make them known to those around you and enforce them. Know your values. Know what gives you meaning and purpose and hope. Remember why you chose this profession in the first place. PALPRAC would like to assist you during this time by offering mentorship, not just on a clinical level, but also regarding the emotions and the psychological work that will be required of you. In the end, the most important message is that each one of us handles the pressure of life differently. This means that only you can tell when things are not going well. Take the time to identify your own red flag signs, whether that be you stop kissing your family goodbye in the morning, or you start drinking 8 instead of 4 cups of coffee per day. You also need to listen to the people around us. Our families and our colleagues sometimes know us better than we think. If your loved ones or teammates go to the trouble of noticing a change in your behavior, listen to them. Adapt your behavior. Seek help early. Whether you need guidance or just need to talk to someone to vent your feelings, reflect on your day or your process or experience. For public health employees, the Western Cape Department of Health has availed the Employee Wellness Helpline on the number listed here. But look around you in your own community for support and services as well. Please see the link to an evaluation which will assist us to improve this course. If you identify any gaps in the training or you've got any questions, please be free to email us at info@palprac or go and visit our website. And thank you for taking time to look at palliative care during the COVID-19 pandemic. Thank you.